Hi, I'm Michael Brand. You may know me from my How to Lose Money on Analytics video series. And I promise the next one of those will be up soon, but this time something different. I wanted to talk about the coronavirus pandemic and what it looks like from the perspective of a data scientist. A bit of background, I've been a data scientist for almost 30 years now, and a year ago started my own company, Otzma Analytics, where I provide analytics consulting and analytics auditing. In analytics auditing, I come to a business that has just started or finished or is at a decision point regarding a data science project. I listen to what the data scientists have done, I look at their methods, and then come up with a series of concrete recommendations regarding what can be done better to get more value from the same project. Sounds abstract? Well, let's make it concrete by looking at the example of COVID-19. So with that, here's an analytics audit of the coronavirus data. Let's go. A few days ago, a friend sent me an email telling me that from what he sees, this whole crisis is just manufactured media hype, and in reality, COVID-19 is no more worrying than the flu. To prove his point, he showed me this graphic. This graphic shows daily mortality rates from various causes around the globe, and to be sure, COVID is pretty far down on the list, much farther down than the flu. So this is an example of someone who has gotten their hands on data, did some analysis, is presenting their results to me, and is asking for my professional opinion on it. A classic analytics auditing style situation. Here's what I reply to them. First, we rarely use global statistics in analysis because they're very misleading and usually not relevant. The universe, be it the global human population in the case of COVID-19 or every line of business in your company when you're doing industrial data science, is heterogeneous. It is composed of many populations that are in many ways completely unlike each other, and simply summing up over all of it makes for nothing but a statistical salad. In the case of global mortality rates, those are mainly dictated by the fact that the vast majority of the world's population lives in developing countries, where access to basic medicine and even to running water is often limited. The fact that in these countries people die at horrifying rates because they do not have access to, say, antibiotics, has no bearing on the severity of a pandemic that is currently ravaging a population that is healthy, well-fed, and with access to the best of medicine. You can't just mix together communicable diseases, non-communicable diseases, microbial with viral, etc. You need to have a relevant slicing of this data, and when you do, COVID-19 is demonstrably a pandemic out of proportion with anything else in the first world. Now, what makes a particular slicing of the data relevant? Well, the question you should be asking yourself always is, why do we need this analysis in the first place? Data science is a tool for informing decisions. The analysis needs to be less about the present state and more about the impact of potential decisions. This particular chart is meant to pacify people into dismissing the criticality of a quick and vigilant response to the coronavirus outbreak, and it does so by looking at what is. That's the wrong question. Here's the right question. How many people can a correct decision at this point save? I don't know how to save the 1 million+ people who die from tuberculosis each year. But choosing our actions judiciously regarding COVID-19, we can save massive amounts of human lives right now. But perhaps the most important point regarding this chart is that the data is just bad data. You can't compare apples and oranges. Every other figure in this chart is a multi-year average for a cause of death that is persistent or seasonal. COVID-19 is new, and its situation is evolving at a rapid pace. The number of deaths per day for it is not a constant, it grows exponentially. The chart says 56 deaths per day from COVID-19, but by the time it was emailed to me, only 10 days later, that number was already 1,000. Right now, it's around 2,000. It's grown 12, 13, 14% every day in the interim. Now, this analysis is quite representative of how data analysis is all too often done in businesses. It's brought in as a political tool, as a way for managers to exert their dominance by showing that they are in the right because they have the power of science. Those are not the managers that call for an analytics audit. Another example of how data is subverted is by how you present it. Consider this image, for example, that has been appearing in a great many major media outlets, not to mention social media. The idea is that by slowing down the progress of COVID-19, we are easing the load on the healthcare system. The graph of illnesses is stretched wider across the time axis, which in turn lowers the peak, which in turn slips it under the horizontal line that signifies the capacity of the healthcare system to cope. Visualization is important, often very useful, but it is never objective. All visualizations have an agenda. Conceptual visualization? Well, they're the worst offenders. They are basically the visual equivalent of an opinion piece. Compare that with the same drawing, only this time a version adapted from an academic paper. This time these are real numbers rather than conceptual. See that horizontal red line all the way at the bottom? That's actual healthcare capacity. This graph tells a completely different story, doesn't it? It tells you that social distancing and flattening the curve doesn't work. The healthcare system has no chance of coping. If its capacity was increased tenfold, it would still be overrun completely. That's why we need stringent isolation measures, and that's why we need them immediately. Okay, so those were cases of an analysis which started with a desired conclusion and worked backwards. That's bad data science. Let's now take instead an example of a good decision-supporting analysis and what an audit of that may look like. As my reference analysis, I'm going to take these two excellent articles by Tomas Pueyo. Links are in the description. Note that the numbers, no matter what I do, are going to be outdated by the time you read it, so make sure that any decisions that you make are done with the best available data, the most current available data. With that said, let's begin with the simple question. What is the fatality rate of COVID-19? There are several ways to estimate this. One, by looking at the convergence between deaths per closed cases and deaths per total cases. This is what Pueyo used. Looking at the Hubei region in China, the number seems to converge to roughly 4.8%. However, here's the graph from China excluding Hubei. Here, the numbers converge to 0.9%. So which is it, 0.9 or 4.8%? Now, this is a problem we encounter quite a lot in statistics. It's a bias which we call a sampling bias. Consider this chart, for example. It shows the positive test rate for COVID-19 in various countries as of March 3rd, demonstrating very high variability between countries. We see 8.7% for Italy, but 21% for the US. Is the situation in the US really 2.5 times worse? No. The positive percentages are the fraction of positives among those tested, not the fraction of positives among the entire population. The question is, who do you test? In the US, as can be seen, testing is very sparse. A person is tested only if they come to the hospital showing severe enough and characteristic enough symptoms to merit testing. There are many hurdles here. In the US, seeking hospital care is a major hurdle. Then there's the question of what percentage will show severe symptoms, which we know from other data sources is fairly low. And then there's the question of whether their presentation will always be characteristic, which, again, we know not to be the case. But even in places where testing is easier to come by than the US, there's still the question of who are we not testing? Who are the asymptomatic ones? Pueyo puts the asymptomatics at 30%, but what is that percent really? A recently published paper analyzing the percentage of asymptomatic COVID-19 presentations based on Diamond Princess data, which is a group of people for whom we tested 100%, estimated it at 35%. But that was based on data that was available February 20th, assuming that people will continue to develop symptoms over time. Looking at the data as of March 18th, numbers seem to have stabilized at roughly 47%. Far more people are asymptomatic, therefore generally don't get tested, than is normally reported. But that's still not the end of the story, because despite the fact that in the case of the Diamond Princess, we've tested 100% of the individuals, this still doesn't solve the problem of sampling bias, because the population of the Diamond Princess, the population of the passengers and crew of a cruise ship, isn't representative of the population at large. For example, children are highly underrepresented, and that is one group whose asymptomatic percentage is suspected to be quite high. If this had been an audit in a business setting, my data science recommendation would have been to simply run a test, take a random sample from the population and test it for COVID-19, regardless of any symptoms, just to get a baseline assessment. This would have been most effective in a country such as the US, where community transmission has become rampant. But even in places where community transmission is low, such as in Australia, the percentage of infections from unknown or yet unknown sources is still quite high, indicating that there may be quite a few asymptomatic carriers out there we don't yet know about, and they're continuing to infect others. In reality, the closest we have to a real estimate of COVID-19's mortality rates is statistics from South Korea, where testing and tracing has been remarkably extensive, to the point that we can now be fairly confident that the majority of cases were mapped. Their fatality rate stands at 0.5%. Now we can work back to reassess how many are asymptomatic. This is not a stable calculation, your mileage may vary, but if we take Pueyo's numbers of 30% asymptomatic and 4% critical, and if putting together with other sources we say that half of these critical cases end in death, that's 2% from Pueyo's sampled population that die. But in order to get that down to 0.5%, what we get from South Korea, we need to supplement it with quite a lot of asymptomatic cases. In fact, so much that the percentage of the asymptomatics grows to over 80%. The reality is probably somewhere in between these two figures, higher than 50% because Diamond Princess population is unrepresentative, smaller than 80% because our calculation was unstable and didn't account for many factors, such as, for example, the quality of the South Korean healthcare system before and during the outbreak. Either way, this indicates that much larger swaths of the population may be carrying and spreading coronavirus than is generally assumed, making isolation strategies all the more important. Okay, off to a different topic. What are the rates of spread in the population? Epidemiologists model this with a coefficient, R, indicating how many people an average individual will infect. For COVID-19, this has been estimated at 2.6, which is twice as contagious as the flu. But if we once again put our auditing caps on, is this the best way to go about it? The reason we calculate R is that it's easy to do. This is pen and pencil statistics, and you can do it based on the sort of data available to epidemiologists in standard situations. But the corona outbreak is no standard situation, and it's quite possible to pull all the stops here. We have today quite detailed maps of population movement. What are we doing with all this data? Well, we can do the invasive, intrusive, and creepy thing and find out for each of us where we've been, whom we've met, and in this way trace precisely the course of any virus. Maybe for containment, some version of that is merited. For the wider population, there are better ways. We can use aggregate data. The point is, we don't have to just blindly aggregate over the entire population. Different population segments will infect at different rates. Take, for example, school children, where we know the asymptomatic rate is high. And even when there are symptoms, they're likely to be confused with much milder conditions. Now, as a data scientist, I usually think in graph terminology. Let's visualize each child as a node in a graph. When two children interact, there's an edge between nodes. For each such edge, if one child is carrying coronavirus and the other not, there is some probability, p, that the other will be infected. To simplify, we'll ignore time delays in this analysis. Doesn't really matter in a school environment. Now let's visualize a classroom. That's essentially a clique of children all interacting. Even if the contagion probability between any specific pair is low, the end result is that if one has coronavirus, many have coronavirus. Now let's look at a school. It's composed of many such classrooms. But now the children go on recess. The classes interact. Because of the initial in-class incubation, that single first contagion has now led to a contagion in essentially every classroom. Back from recess, those few infections per classroom now become a school-wide pandemic. Considered in graph terms, even if an average person infects only 2 or 3 other individuals, a school is a petri dish, and these children tend to be asymptomatic and return to their families where there will be more infections. This highlights why minimizing the number of children physically attending school is critical for stemming virus spread. This kind of detailed modeling is what allows us to predict how each countermeasure meant to contain the coronavirus is likely to impact it. It demonstrates, for example, why the South Korean measure of allowing only a single designated individual from each household to leave the house, for example for shopping, is extremely impactful in lowering the spread. This is not an obvious conclusion, and it's one that you can implement in your household right now, regardless of any government directives. Now, I want to point out that Pueyo's stance is that after the initial outbreak of Covid-19 is squashed, you can run experiments with different containment strategies in order to get the population R still below 1, which is the critical level, but ease the social measures as much as possible. Active experimentation is the scientific way of going about it, and I can only applaud Pueyo for suggesting it, but good modeling allows us to predict better, meaning that we can run fewer of these experiments at a dramatically reduced cost to both individuals and society to arrive at the optimal strategy. As a last point, I want to discuss an example of how one can get 2 diametrically opposite conclusions from the same data. Commonly cited advice is for people to get their flu shots as soon as they are available. This is true always, but has gained an added momentum now with COVID-19. Doctors say that while the flu shot does nothing to protect you from coronavirus, what you don't want is to catch both of them at once, making the combination much more severe and harder to treat. A secondary advantage, of course, is that it will take a lot of load off of the healthcare system that would otherwise be busy treating people for the flu. On the other hand, here's Dr. Martin Blazer.
When you have a viral infection, your immune responses are all revved up. And so usually you do not get a second viral infection. If you have the flu and coronavirus lands on you, probably your revved up immune system will eliminate it.
What the actual medicine is, I don't know. I'm not a medical doctor. And I absolutely don't recommend that anyone of their own accord try out any non-FDA approved treatment. But consider this hypothetical. Suppose that a person with the flu has a revved up immune system, and that if a person with such an immune system encounters the coronavirus, this both protects their body for a short period of time from infection and simultaneously allows it to build up specific immunity to coronavirus that will protect them in the longer term. This person has just become inoculated to coronavirus. They may still die from the flu, but the point is that flu mortality rates are much lower and the flu is much more treatable. And you can repeat the same analysis with something other than the flu. Perhaps there is some other virus X that is safer to use that can provide such a shield against COVID-19. Perhaps if we could judiciously expose people to X and then judiciously expose them to coronavirus, we can build their immunity in this way. Essentially, this is creating a vaccine. These are, let me repeat, wild speculations, and the truth is that the time it would take to test them and develop them into a viable treatment, even if they work, is no shorter than the time to develop any other vaccine. So please, please, please don't try this at home. My point is to demonstrate how from the same data set one can reach radically different conclusions, and how the conclusions of a domain expert may be biased in ways that are not relevant to the specific problem at hand. In this particular case, a medical domain expert who, in the normal course of events, would encourage people to get vaccinated against the flu may have a cognitive bias that would block them from seeing a possibility that involves actively encouraging people to be infected. It's an unusual circumstance. It can lead to an unusual solution. So there you have it. An analytics audit over an excellent and well-meant analysis. Nothing dramatic was broken, but we've demonstrated a sampling bias and some ways to correct for it that suggest that the magnitude of the invisible problem of asymptomatic carriers is perhaps much larger than projected. We've shown how more advanced modeling techniques can dramatically alter our ability to predict and respond appropriately, and we've shown how a fresh pair of eyes looking at the same data can reach a very different conclusion by challenging some basic assumptions. This is what happens at analytics audits. I'll see you soon with the next installment of How to Lose Money on Analytics. In the meanwhile, stay healthy, stay safe.